Good afternoon, everyone. Thank you for the organizing and scientific committee to invite me to speak about this topic. That's really interesting. So we'll speak about some data about liver radiotherapy, as well as establishing radiotherapy SBRT program, and we'll discuss some cases afterwards. I'll try to limit the time for the clinical evidence because I would like to discuss the practical aspects more in this presentation. No disclosures. So this is the first report of a group that treated liver SBRT. It was from Scandinavian countries, data from about 30 patients, and that was published in the 90s, mid-90s. And you can see here that they used things that we use currently, like abdominal compression, even the concept of getting maximum inhale, maximum exhale to imitate 4D CT. They also fused with MRI diagnostic. So they did a pretty good job for that time. And the results were also good in terms of local control. Toxicity is not so much because we didn't really understand the effect of radiotherapy on liver very well at that time, especially in cirrhotic patients, but it was a good start. So then modern studies in beginning of 2000, 2010, and afterwards, groups published their trials, and group in PMH in Toronto was very, very active in that point of view. So this is an analysis of two trials that they did of 100 patients, good child PO-A, and they spared a normal tissue of the liver. Prior therapies were allowed, and they allowed up to 15 centimeters of maximum lesion, and they allowed up to 5 liver lesions. Very good biological dose of up to 54 gray in 6 fractions. Results were very good. So local control reached up to 87%, and no classic radiation-induced liver disease was reported. Decline in child PO score was noted about 6% at 12 months. So this is really good toxicity profile compared to the previous study that I mentioned earlier. We know that the ones who do better are usually the ones who do not have metastatic disease, the ones who do not have tumor vascular thrombosis, which is almost equivalent to having metastatic disease in HCC, especially if it's macrovascular. Those who are in good performance status and lower child PO score also do well. So toxicity profile in general, this is really safe treatment with modern treatment and modern reported radiotherapy trials for the liver, with a grade 3 toxicity not being high, and very low grade 4 and grade 5 toxicity. And predictors of toxicity included multiple factors, and those are similar to bad factors that caused decrease in overall survival or local control, including thrombosis, especially of large vessel, very bad child PO score, not just child A, B, and C, but even within A. So A5 do much better in terms of toxicity compared to A6. Low platelet count was associated with with bad toxicity. High mean liver dose and not controlling D800 or D700 cc was also associated with worse outcomes. And the D800 or D700 cc is a concept that we radiation oncologists stole from hepatobiliary surgeons and implemented it, and it's working very well for us. So you can see here the difference between A5 versus A6 in terms of toxicity profile. And they reported also data of correlation of D800 or D700 cc, if you're using it more often, to mean liver dose. The lower, the better. Unfortunately, that's very difficult to reach sometimes in cirrhotic patients with small livers. So you have to correlate to a certain trial to know what dose to give. And we do have a randomized evidence, which is really good, a clinical trial, RTOG 1112. That was the first randomized trial in SBRT for HCC, similar patients to previous trials, sorafenib, standard of care at that time versus SBRT plus sorafenib with very good radiobiological dose in 5 fractions, so 27.5 up to 50 gray in 5. It improved overall survival, so not just local control. So this is one of the few things, or one of the things in radiation oncology where we improve survival. A meta-analysis, which will be the last clinical data before going into the technical part. A meta-analysis of multiple data was done, published in Red Journal 2 years ago, showed excellent outcomes with some studies from this region. So overall survival is really comparable to other modalities at about 57% at 3 years with very good local control of up to 84% at 3 years, and that's consistent at 5 years. And it didn't change much when you compare less than 3 centimeters compared to more than 3 centimeters, which is really better than other modalities in terms of local control, so RFA, TACE, and the rest. Toxicity was really minimal. Some reported biliary toxicity, but that's really rare. So with all of that, the BCLC changed their guidelines of 2022 to include external beam radiotherapy in their recent 2025 guideline, and recommended that in certain situations as standard of care. So that's something that you can argue with insurance companies or with other modalities in MDTs to advocate for radiotherapy or SBRT. Multiple guidelines and societies also acknowledge radiotherapy to be standard of care in certain situations, including these societies. There are other modalities. You need to know which one to choose in certain situation. Usually SBRT would be the modality where you can use in almost any situation, large or small lesions, close to critical structures or far away, as a bridge to transplant or as a palliative or as a curative treatment. SBRT can be used to, in liver metastases with good local control. Of course, there is heterogeneous data, some with very good local control, some with less local control, but that's just the heterogeneity of metastases and the tumors, mutations that's inside it. But nonetheless, very good data. So clinical data in liver, we can speak for an hour about and not finish, but I'd like to speak about liver SBRT workflow and liver radiotherapy general workflow in the remaining time. So generally we start with simulation. There has to be a good motion management technique. We'll speak about some of them soon. Planning some points we'll mention soon, and then very good verification before delivery. So we'll speak about our program. So we treat about 90 patients a year on average. The number has been increasing over the years. So we mainly use CT simulation and MR simulation to all of our liver SBRT patients. And MR simulation is standard unless patient has any contraindication or cannot do that. It took us a while to improve the quality of the MR simulation for liver because of the motion that can happen. We never use PET simulator just because the motion will be difficult really to control where the disease is. We mainly treat our patients on either CyberKnife or TrueBeam, sometimes on Versa HD. We never treated them on tomotherapy. So triphasic liver CT sim is really an essential component in this program, especially if you're treating HCC. It really changes your volume. It's a must, and it's an easy thing to do. So it's the same contrast that you're gonna do to your patients anyways if you're using contrast, but only the timing. So you just get an arterial phase, venous and delayed venous with the same amount of contrast. Easy to implement, but you need to if it's not yet implemented in your institution, collaborate with your radiology department, ask them for their technicians, have their protocols implemented. and then ask them to supervise your radiation therapy staff for at least the first 10 patients. That's what we did. And our staff are now very efficient in doing that. Immobilization, so multiple techniques can be used based on what you have at your center. People can use a simple abdominal compression with its multiple companies that provide it. You can also use some commercially available options like body fix, just to control the patient more, combine both, and that's an option that's available. If none of that is available and you just have a VAC lock, you still can do liver SBRT. You have to be cautious with your margins, though, and with your dose and your organ at risk movement, but still can be done. MR simulation really improves the contouring accuracy. Multiple ways of doing registration with MR simulator, including rigid versus deformable. I personally, and most people would prefer rigid registration in that scenario. It doesn't really work very well, the deformable registration with liver, and you really have to register liver to liver rather than spine to spine, because you will never have the liver in the same location with those two simulation scans. So I want to mention a few words about this sequence. We use it from time to time, not in all patients. I mean, maybe 5% of patients. MRI Primovist, so there's a special contrast that our colleague radiologists use. It's an expensive contrast, so they don't like when we order it, and they want a justification. It's good contrast to delineate the lesion, not the best in that, but really important in ruling out other lesions in the liver. So that will give you more grounds into increasing your dose to the liver. For example, I would treat an oligometastatic disease that's located in the liver, single lesion, with much higher dose than if I would treat multiple lesions to control the disease. So I'd like to show you these scans just to show you the importance of triphasic liver CT SIM. So you can see on the right side of the or the left side of the screen, CT scan for this patient who is in his 39 years old, who was found to have HCC incidentally when he presented to the emergency department, multiple comorbidities, so he wasn't eligible for other local regional control modalities, wasn't also eligible for transplant because of major vessel invasion. Triphasic liver CT SIM was used to delineate the disease very well. You can see a clear arterial enhancement on the upper side. And then you can see just below that, the washout in venous and delayed venous phases. So that's characteristic of HCC, and you need to meet both of those criteria in order to define the disease. So he was treated with 35 Grays 5 fractions initially and had really good response for up to 4 years. Then had, unfortunately, a recurrence that was treated using MR-Linac and treated again with good response. An essential part of any SBRT program for liver or lung or moving target is a 4D CT. So CT data sorted into multiple respiratory phases, and this is acquired through external respiratory surrogate, either infrared marker or belt-based system. I would caution you here with the belt-based system that sometimes you would have a slight compression on the abdomen where the arc is going to rotate around the liver, and that slight compression might change the dose calculation by 1% or even less if you're going to be that accurate, because it's not going to be there at time of treatment. One way to overcome this is to get a free breathing scan at same position and register both. We do have the belt-based system in our center. So that planning with 4DCT will be ITV based, so contouring the target in all phases and then combining them.
1 minute only.
1 minute?
Yeah.
Oh. Well, I need like 10.
Although it's interesting.
So we'll speak then faster. So gating assessment, you need to assess gating in those Patients, multiple available options, RPM with your Varian machines, or ADC with your Versa machines, or Synchrony. We do have the RPM and the Synchrony, and Synchrony, we use it with our CyberKnife. I'll show you an option shortly. So bottom line from this slide is you have to do fluoroscopy. It's not a must, but fluoroscopy to assess the diaphragm motion reproducibility in patients who pass gating assessment. So they hold their breath for 20 seconds. You take them to the LINAC. Your physicists and therapists are not going to be happy about that because you're wasting machine time. But that's the only way to know how reproducible is your setup. It's not a must, but it's good if you can do it. We do prefer exhale-based gating because it's more reproducible for the upper abdomen organs. Tracking can be used. Multiple systems available. We do treat some of our patients using CyberKnife, and insertion of fiducials is a must, and you have to have a good collaboration with your interventional radiologist. Certain criteria should be done for that. There's no time really to go through it. And then you have to contour your organs at risk very well. We do use, and I really advocate for oral contrast with IV contrast, and specific timing has to be done correctly. 15 to 20 minutes is a good time generally on empty stomach to have a good delineation of the duodenum and of the stomach that's really going to be close to the liver. Triple F beam is a standard in those cases. So this is a good article to see how to delineate those normal organs. You don't have to contour segments like in here, but that's a good reference. But it's good to contour these structures like the biliary tract and vessels, especially in patients who are bridged to transplant, just to help our colleague surgeons. A concept I'd like to mention in this slide is, well, actually two things. So a plan of the day concept is something we do sometimes, especially in centers that do not have adaptive radiotherapy or MR LINAC, like our center. So we do have a plan for patients when their ascites is full, and then when their ascites is drained, and then we do plan of the day sort of thing. We activate the plan that's similar to patient presentation on that day. There is no time to go through this slide as well, but I'll mention a case that can represent the Y90 situation with SBRT. So this patient in his 80s, performance status of 2, multiple comorbidities, including CKD, multiple local regional therapies for HCC with non-complete response, tear twice, so previous radiotherapy. He was referred to us because no other options were available for him, and SBRT was recommended at MDT. We treated him with 40 grays and 5 fractions, and in this, you do not really have to account very well for the tear. Previously, remember, tear has small energy, not more than 1 MeV, so it doesn't travel really far. Your mean liver dose should not be affected a lot, and you can get help from your colleague interventional radiologist to see their mapping if you're concerned about any organ and at risk. He had really good response, complete response, and no evidence of viable disease on follow-up. This is a gating, exhale-based gating case. So a patient in his late 40s who had GE junction adenocarcinoma diagnosed in 2023 and underwent treatments, including cross-protocol standard at that time and surgery. 3 months ago, we discussed his case in MDT, and on surveillance, he was having oligometastatic disease in his liver. Patient is not keen for surgery. Systemic therapy is to be started, but they needed a local control modality, and SBRT was suggested. You can see here, SBRT was provided with 50 gray and 5 fractions. You can see something like the contrast on the upper side of this the upper side of this screen over here. So he had a gastric pull-up, and because the timing of the contrast was not optimal at the machine, I think the image was taken like 5 or 10 minutes after contrast. It didn't have time to go to his upper bowel, so it wasn't of a really good use in his case. Shows you the importance of timing. And then last case. Sorry. So last case is tracking based treatment using CyberKnife, a patient in his in her 50s with oligometastatic breast cancer to liver, referred to me from her medical oncologist after undergoing multiple treatments, so lumpectomy in 2020, and received adjuvant whole breast radiotherapy as well as boost to tumor bed, and has been going through hormonal therapy. On surveillance scan, unfortunately, she had a metastasis in the liver. It was oligometastatic. She wasn't really keen for any surgery, and she was tired of systemic therapy and just wanted some sort of break and no aggressive treatments. So in her case, we used a fiducial marker inserted around the tumor, 3 of them. We were able to track 2 of those. And we did CT and MRI simulation. MRI simulation in her case is of a great importance because you can see the metal artifact caused by those fiducials. It's important to do the scan 2 weeks after fiducials, just in order for them not to move just after insertion, although there is special kind now where you can just do simulation same day. She received 50 grades in 5 fractions. 3 months post-treatment, complete response was noted. You can see here the beam entry and exit profile for this patient. Because she received previous chest radiotherapy and because she received chest wall dose and breast radiotherapy and breast tissue radiotherapy previously on the same side, we wanted to make no entry, no exit through the previously irradiated area. So you can see here the breast spared from radiotherapy and the chest wall dose over there implant sum is negligible. So that's it for this presentation. Thank you so much.
Thank you. Great talk. Just a quick comment on the case one that you showed. I noticed the tumor, when it's closer to the stomach, you chose to reduce the dose, right? With a PED of around 70 gray. So one thing just to consider, and we can discuss offline for time constraints, is perhaps choosing hypofractionation instead of reducing the dose, just so you can go above a PED of 100 while still protecting the luminal organs that are nearby the target, especially for tumors in the left lobe or those that are close to the duodenum or the stomach, where you're really limited by the constraints.
Yeah, that's a really good suggestion, and we do use it from time to time in our patients who are accepting of staying in Riyadh for more than the week of SBRT. It's a very good option and very good thing to do.
Thank you, Professor.
Thank you.